Section 4 of Endocrinology, Adrenal Disorders, Hypercortisolism, Hyperparathyroidism, and Hypocalcemia. If you understood USMLE Step 1 physiology for endocrinology, you'll be at a huge advantage here for your Step 2, because you will now recall that every morning out of your hypothalamus comes corticotropin-releasing hormone, CRH, which goes down to your pituitary and makes ACTH and down to the adrenals to make cortisol, and you must intrinsically understand this axis to understand anything we're going to say in this entire section, because cortisol's function is to go throughout the body and make free fatty acids and glucose go up, because that's what you get every morning. You get a cheese Danish in bed with fat and sugar, and that's it. The demarcations between Cushing's disease and Cushing's syndrome are not as important as simply saying, is this a pituitary overproduction of ACTH, or is this a problem with the ectopic production of ACTH? That's the most important thing, because that's what drives the testing and the treatment. See, what the problem really is trying to identify where it's from. That's the number one issue for you with hypercortisolism. Is it originating in a carcinoid, such as the most common is a small cell carcinoma of the lung? Or is it autonomously overproduced in the adrenal gland? And the reason why this is important is because since prednisone or any glucocorticoid use can also cause the same manifestations of hypercortisolism, your big issue is, where's it coming from so I can remove the right organ? The causes of hypercortisolism, the majority of them are from the pituitary. Now you see that we put as the major calling of it, the major naming of it is pituitary, because that's clear. It's different than saying, well, Cushing's disease, Cushing's syndrome. Oh, pituitary is overproducing. Now I know where it is. The adrenals is simply much less common. Ectopic is even less common, at only 10%. And then, unfortunately, about 5%, we just never figure out the cause. The reason why this is so critically indispensable is that people have had their pituitaries removed when it was really coming from the adrenals. So make sure you know where it's coming from so you remove only the correct organ. You can't determine the site of the origin of the disorder just by the symptoms. You see, no matter where it's coming from, they all cause a moon face, truncal obesity, buffalo hump, thin extremities, abdominal fat. Why does the fat redistribute? Well, nobody really knows. We do know that Cushing's disease and hypercortisolism in general raises free fatty acid levels, because we want that fat so you can run away from things. That's a tremendous stress hormone. Now, why does it melt the fat in your extremities and increase the fat in your neck and your abdomen? Man, nobody knows. And if you figure it out, get a Nobel Prize. But all we know is that the skin gets thin, but stria and bruising and decreased wound healing, thinning of that skin, because we're taking the collagen in the skin and transforming it into sugar for gluconeogenesis. We're taking the proteins in the bone, and remember, bone is calcium encrusted amino acids. Calcium encrusted amino acids. Melt that bone to make the sugar. Hypertension is for two reasons. One, there's increased sodium reabsorption, and that's because no steroid is entirely glucocorticoid or entirely mineralocorticoid, and glucocorticoids like prednisone, glucocorticoids like cortisol have some mineralocorticoid activity as well, such as aldosterone-like effect. Therefore, you get hypertension because all steroids are a bit mixed, and it is the mineralocorticoid or aldosterone-like effect of the cortisols that make it increase sodium and therefore increase water. Also, this raises the blood pressure, and there's also an increased vascular reactivity. That means that if you give a patient epinephrine and norepinephrine, and one patient has the cortisol and the other one doesn't, the one that has the cortisol will have a greater vasoconstriction. Cortisol and glucocorticoids increase vascular reactivity. It means it gives your blood vessels a greater squeeze. Menstrual disorders are part of that fact that the steroids are not pure. The same way that even the glucocorticoids have a little mineralocorticoid activity, a little hypertension. There's also some androgen-like activity, and that's not really cool for your menstruations. erectile dysfunction as well in some patients. That one's not as clear. And polyuria because of the hyperglycemia. The hyperglycemia causes an osmotic diuresis and increased free water clearance because it literally sucks the water right out of you. The bottom line is, number one thing, always confirm the source of hypercortisolism with biochemical tests. Before you image, do biochemical tests. That is because 4% of the population has adrenal tumors and 10% of the population has abnormalities of the pituitary. If you start with a scan, you may remove the pituitary when the source is really in the adrenals. What'd you do? Oh, I scanned you. What happened? Well, we took out the pituitary with transsphenoidal surgery. How'd it go? Well, the surgery went very well, except for the fact that the problem was originating as in adrenals. Oh, you didn't check the ACTH level first? No. Oh, that's bad. Biochemical confirmation so that the scan is more or less after the fact. Hey, I got a high 24-hour urine cortisol. I know you got hypercortisolism. Oh, and there's a high ACTH. It's in the pituitary. It's in the pituitary. By far, the most complex thing in hypercortisolism is the diagnostic evaluation. If you start out with a chief complaint like, I feel weak and tired, and I notice that the hair growth on my face is abnormal, and there's some strange marks on my belly, which is basically stria. The hair growth is because of the androgenic capacity of the cortisol. The first thing, and this is not random, by the way, there's nothing random on this algorithm. The first thing to do is the 24-hour urine cortisol. You see, the 24-hour urine cortisol is normal. You have essentially excluded a person's hypercortisolism. A normal 24-hour urine cortisol 100% excludes it. Now, the question is, a 1 milligram low-dose dexamethasone suppression test, a one-night overnight dexamethasone suppression test. This is a fast screening test that, if it's normal, excludes it as well. If it's elevated, you're not sure what to do with it. The same with late-night cortisol studies. See, a late-night salivary cortisol, although it's not done very much, it's still important. It can still appear on your test. You see, when is cortisol normally high? The daytime, morning, or night? When is the cortisol high? Well, cortisol is high in the morning because it's what gets you your get up and go in that morning. So at 11 o'clock at night, it should be at its lowest. So if your late night cortisol is up, ooh, that's bad. You probably have hypercortisolism. Now, a 24-hour urine cortisol is increased. The reason why we do that test, even though it's harder to do, is because if it's increased, it really means you have hypercortisolism. There are very few false positives on a 24-hour urine cortisol. When we're upset, when we got to run for a bus, when we're late for something, our cortisol level goes up. However, it goes up just for a second, a few minutes. It doesn't go up all the time. How do I tell if your cortisol level's up all the time during the day? 24-hour urine cortisol. The same way, if the police are doing surveillance on you and they want to know what you've been doing for the last couple of weeks, they go through your garbage. That's what it's like in the urine. Going through the garbage, seeing what you got in there. Now, a low dose or 1 milligram overnight dexamethasone test, if it's normal, if it's decreased, disease is excluded. In other words, if it suppresses, you have conclusively proven that there's not hypercortisolism. A 1 milligram overnight means no disease if it's normal. The problem with that test is that if it's up, there's a lot of false positives. But if it's down, you've excluded the disease. That's the 1 milligram overnight dexamethasone suppression test. An increased late-night cortisol in the saliva is very strongly suggestive of hypercortisolism. So 24-hour urine cortisol is the answer to best initial test, and it is also the answer to more specific. These tests, however, are all to prove that you have hypercortisolism. These are tests to prove, disprove whether you have hypercortisolism. They are not to determine the etiology. The etiology is determined by ACTH levels. Once the 24-hour urine cortisol, late night salivary cortisol is up, then we get an ACTH level, because that's going to help us to know, hey man, it's high, it's ACTH dependent. Oh man, it's in the pituitary or ectopic. It's in the pituitary or ectopic. Oh no, it's low. Ooh, it's adrenal overproduction, because if it's low ACTH, it's adrenal overproduction. It is the adrenal gland making cortisol independently. And that's why we use the ACTH to tell you, hey, if the ACTH level is up, it is from the pituitary or an ectopic focus. If the ACTH level is down, ACTH independent Cushing syndrome means it's happening in the adrenal gland. By far the most complicated feature of all questions on hypercortisolism is a diagnostic test. Ultimately, we're simply going to remove anything we find. But you've got to make sure you're going to remove the right part of the body. This is because 4% of the population has an adrenal lesion, an adrenal incidentaloma. 10% of the population, which increases, frankly, even larger above that in an older population, can have a pituitary lesion. Therefore, unless you're certain biochemically before you remove the organ from the person, you could very well end up removing the wrong source. So the rule for you in endocrine is never start with a scan, and the second thing is confirm the location biochemically before you do any imaging studies. So ACTH-dependent Cushing syndrome means that it's originating from where ACTH is made, and ACTH is generally made in the pituitary. Now, an ACTH-independent lesion means that the adrenal is making the cortisol independently without stimulation from its master gland in the pituitary. You'd start with a CT scan of the adrenals after you see that the person has hypercortisolism and a low ACTH. Hypercortisolism, such as an increased level on a 24-hour urine cortisol, plus a low ACTH level equals scan the adrenal. Low ACTH equals scan the adrenals. When the ACTH level is high, it could be either from the pituitary or ectopic production. Now, ectopic production can be either, say, a carcinoid lesion or an ectopic focus of ACTH-producing tissue, or it can be from a cancer. What we know is that cancers and ectopic foci simply don't suppress. They don't subject themselves to the normal feedback inhibition. We know that the pituitary will. So we know that if there's an increased ACTH and a high cortisol, that what you'll see is that there's still a failure of suppression. If high-dose dexamethasone does not suppress that production, there's ACTH secreting ectopic tissue. And we look for that first inside the chest. Now, if there is suppression with high-dose dexamethasone, it turns out pituitary lesions, such as pituitary adenomas, still retain enough normal function that it will suppress. So therefore, at high dose, the dexamethasone will suppress pituitary lesions. So the bottom line is pituitaries suppress and ectopics don't. After you have suppressed it with high-dose dexamethasone, you will scan that pituitary. Remember how we said don't start with the scan? Well, you can certainly end with the scan. Now, if there is still, you don't see a lesion in there, well, there still is a lesion in there. That's the problem with the scanning. 10% of the general population has a pituitary lesion. If you start with a scan, you might remove the pituitary incorrectly. The other part of it is that you could still have pituitary secretion of ACTH with no mass seen. That's why we sampled the petrosal sinus for ACTH. Now, this is the most complicated version of all of the endocrine lesions, and therefore you should expect to have to go through this a couple of times. This bottom line, literally the bottom line in this algorithm is this. If you have hypercortisolism, do an ACTH level. If the ACTH level is high, you should try and suppress it with high-dose dexamethasone. Ectopic foci and cancers simply won't suppress. Go looking for them inside the chest CT. Pituitary lesions will suppress. So if you suppress them, but you still can't find the thing on a pituitary MRI, you've got to actually put a catheter up there into the petrosal sinus, which is the venous sinus that drains the pituitary, and bind the high ACTH level, which confirms it's an ACTH-producing pituitary adenoma. Let's summarize out the confirmatory laboratory findings in adrenal disorders and hypercortisolism. First off, the ACTH level. Now remember, this is in a person we've already established has hypercortisolism. If you know that there's hypercortisolism, where is it from? The first thing is, if there's a low ACTH level, it's inside the adrenals. Because the adrenals overproducing cortisol and resulting in feedback inhibition on the pituitary. The adrenals overproducing cortisol and having feedback inhibition on the pituitary, so it's shutting off the ACTH. Now, pituitary and ectopic foci are a failure of normal feedback inhibition. They're a failure of normal feedback inhibition, so that's why the ACTH level is abnormally high in the presence of hypercortisolism. So when are we going to do the petrosal sinus sampling? Well, the petrosal sinus sampling is not for the adrenals because the petrosal sinus is what drains out the pituitary. This is done if the MRI is negative. And we go, wait, man, you got a high cortisol and a high ACTH. It must be in the pituitary. Yeah, but my MRI didn't show me anything. Nah, get in the petrosal sinus. It's there. Ectopic foci won't have anything in the petrosal sinus, won't have ACTH in the petrosal sinus, because the petrosal sinus is draining the pituitary, not that ectopic focus. High-dose dexamethasone is very straightforward. High-dose dexamethasone has nothing to do with the adrenals. It has to do with telling the fact that ectopic things don't suppress. Ectopic things don't suppress, and pituitaries will suppress cortisol. Pituitaries are suppressed by high-dose dexamethasone. Pituitary lesions are suppressed by high-dose dexamethasone. The other laboratory findings of hypercortisolism are easier for us to understand because there's only one uniform presentation. Since cortisol is an anti-insulin stress hormone, you will see high sugar and high lipids. It is, in fact, exactly like insulin in the sense that if insulin lowers glucose, lowers lipids, and builds protein, cortisol raises glucose, raises lipids, and destroys protein because it wants the protein for gluconeogenesis. That is the basis of the bone and skin findings. Melts that protein. Now, because there's some aldosterone-like effect to cortisol, you should expect to see hypokalemia because aldosterone makes you retain sodium and excrete potassium. Makes you retain sodium and excrete acid. So there'll be metabolic alkalosis because the aldosterone is making you retain sodium and excrete potassium and excrete acid. In addition, everyone will have a leukocytosis because the stress hormone demarginates white cells. Demargination means half of white cells are normally in circulation, the others are on the edge of the blood vessel, the margins, so to speak, and steroids will pull them off the margins. So working backwards, what is the point of torturing ourselves learning all of those diagnostic tests for hypercortisol? And the answer to that is very straightforward. Whatever we find, we have surgical removal. The point is surgical removal of the source of the hypercortisolism. If it's in the pituitary, crawl up your sphenoids and transsphenoidal surgery for pituitary sources. If it's in the adrenal, laparoscopic removal of the adrenal source or inside the lung. The major point of all of those diagnostic tests is help me to make sure I remove the correct part of the body. An adrenal incidentaloma means a lesion in the adrenal found when the abdominal CAT scan is done for other reasons. With the advent of so much widespread radiologic evaluation, I had appendectomy last year and I had an abdominal CT. What if they'd gone through my adrenals and they'd seen an adrenal incidentaloma? Oh my God, hey fishy fish. Conrad Fisher, you've got a lesion in your adrenals. What are we going to do about it? Well, this is very straightforward. How far should you go in the evaluation of an unexpected asymptomatic lesion? And there's the recommendation by the American Endocrine Association. The endocrinologists basically say, do the metanephrines of blood or urine to exclude pheochromocytoma, renin and aldosterone levels to exclude hypercortisolism, because hypercortisolism We'll have a high aldosterone and a low renin, high aldosterone and a low renin. And this is the only time that a 1 milligram overnight dexamethasone suppression test is all you have to do. The reason is you're doing this test to be negative. Since it's an asymptomatic person, you should expect it to be negative. And what we're doing is we're saying, give me 3 fast tests to make sure that I don't really have anything in that adrenal incidentalloma. You are going to get more and more questions on adrenal and pituitary incidentallomas because we CT and MRI everything. So we've got to be sure we don't overtreat people. Addison's disease is easier than hypercortisolism, mostly because the number of causes of Addison's disease are much smaller. There's much fewer causes. The days of so many infections doing it in Waterhouse-Friderichsen syndrome and meningococcus causing a problem inside the adrenals, that's rather passé. The vast majority of Addison's disease is chronic hypoadrenalism, which in the majority of cases is more common than everything else put together, simply autoimmune destruction. It goes along with vitiligo, and it goes along with monoclonal gammopathy of unknown significance, and it goes along with pernicious anemia, vitiligo, monoclonal gammopathy of unknown significance, and Hashimoto's thyroiditis. Those things travel together. They are basically antibody noise, autoimmune noise throughout the body. So when you see Addison's, you should be thinking about Hashimoto's and vitiligo and pernicious anemia. And when you see pernicious anemia, you should be thinking about Hashimoto's and Addison's disease. Infections can do it in tuberculosis, but infections are much less common. And this is adrenal leukodystrophy is a congenital genetic anomaly of unclear etiology. And sometimes cancer metastasizes to the adrenal and unfortunately can destroy it. Our question about adrenal crisis, well, we have to think backwards from what do we know that adrenal hormones do? Adrenal hormone, most importantly, maintains blood pressure with aldosterone, maintains acid-base status, potassium, acid-base, and blood pressure. So if you have acute adrenal crisis, interestingly enough, the thing that kills you when it says which of the following is most likely to kill the patient, or what will you notice most importantly, that the most important thing is not the loss of the cortisol. The most important thing, the acute adrenal insufficiency, is that your blood pressure drops. Now, sometimes this can be hard to determine because hemorrhage, surgery, hypotension, and trauma don't just result from adrenal crisis. They, in fact, cause adrenal crisis when you underperfuse those adrenals. In addition, suddenly stopping chronic high-dose prednisone can result in adrenal crisis because the body gets used to those hormones all the time. When you suddenly stop them, all of a sudden, bang, they're out of gas and hypotensive. No matter what the etiology is of the low adrenal function, patients are weak and fatigued. Remember that cortisol is a get-up-and-go hormone. It's a get-up-out-of-bed, circadian rhythm, how do I get some energy in the morning hormone. You get altered mental status because the hypoperfusion, the low blood volume, can also contribute to nausea and vomiting, anorexia, hypotension. And if it's chronic, there's hyperpigmentation because there's an increased ACTH coming out of that pituitary, trying to stimulate your adrenals. Acute adrenal crisis presents with profound hypotension, fever, confusion, coma. Holy crap, man, let's draw a cortisol level and give us a stress dose of steroids. In most patients who have hypoadrenalism, because cortisol raises glucose, there's a profound hypoglycemia because adrenal hormones such as aldosterone make you excrete potassium. There's hyperkalemia. And because it also makes you excrete acid, you should see metabolic acidosis, hyponatremia. Well, that's because aldosterone makes you retain sodium and excrete potassium and excrete hydrogen ions. So you don't have aldosterone, you retain potassium and retain the hydrogen ions and excrete the sodium instead. Because you're pre-renal, because you're volume depleted, because you're intravascularly volume depleted and hypotensive, you get a high BUN. Because of the etiology, such as being autoimmune or allergic, eosinophilia is common. Also, steroids get rid of eosinophils. Eosinophils are a sign of allergy. Cancer, allergy, Addison's, wow. So that's why it is steroids get rid of allergies, and if you have no steroids, it's like you're allergic to your own adrenal. Now, with pituitary failure, your ACTH level is low. And with adrenal failure, your ACTH level is high, because when you have pituitary failure, your adrenals are failing at least for the sex hormones and the cortisol. It's failing from the fasciculata, which makes cortisol, and the reticularis, which makes androgens. And therefore, your ACTH level will be low, because this leads to the failure of the fasciculata and reticularis. Now, when there's adrenal failure, your ACTH level will be high, because remember, the only feedback inhibition on that pituitary is cortisol. And if you have no cortisol, you lose feedback inhibition, the pituitary shoots up the ACTH. Hypoadrenalism of any cause results in weakness and hypotension. If it goes on for a while, weight loss and hyperpigmentation, because when you have an insufficient adrenal, you often can have hyperpigmentation from pro-opiomelanocortin. Pro-opiomelanocortin is the precursor protein that comes out of that pituitary. It's like the precursor hormone. Now, we don't know what melanocyte-stimulating hormone does in the normal person. We do know that it results in hyperpigmentation in people who have chronic insufficiency. Now, what we want to do is we want to give that person to test their adrenals to see if we can give their adrenal gland a kick in the pants. So we give artificial ACTH and say, okay, did your plasma cortisol level go up when we gave you the ACTH? Are your adrenals, are they functional at least? Well, if we see a lack of rise of cortisol, then we got to think about two things. Number one, is it that the ACTH is high and the aldosterone is low too, because there's just the adrenal gland has failed. The whole adrenal has failed, and that's because the ACTH level is high all the time, and even the extra kick in the pants didn't work, because it's basically dead gland. Dead gland. How do we know it's dead gland? Because the cortisol doesn't rise, and the aldosterone is low too. Now, what if there's a low ACTH and the aldosterone is able to stay up? Well, that is a person who has basically an insufficient pituitary. See, their pituitary is gone, so what's ended up happening is that the adrenals have atrophied. I don't like terms like secondary adrenal insufficiency, but that's the term. It means that the adrenal is insufficient secondary to a weak pituitary. The adrenal gland is insufficient from a weak pituitary, and it's atrophied from pituitary insufficiency. Now, in an acute adrenal crisis, you are going to die if you don't get some treatment. Treatment is far more important than testing an acute adrenal crisis. You take that cortisol level, you take a cortisol level, and instantly hit them with steroids and hydrocortisone and fludrocortisone sometimes. Remember, fludrocortisone is the steroid that has the highest mineralocorticoid activity. But in acute adrenal crisis, checking the level of cortisol, you don't wait for the results. You take the cortisol level, and if the question is very clear, it's going to say, what is the next best step in the management of this patient? And your answer is cortisol level and replace the steroids. But if you actually had to choose one thing, fluids and steroids is more important than testing. Fludrocortisol is for people who are orthostatic from postural instability. In other words, what keeps your blood pressure up when you go from sitting down to standing up is that you have aldosterone coming out of your adrenals that maintains your blood pressure. And if you don't have enough aldosterone, let's replace it with fludrocortisone. Now, this is a steroid hormone that's particularly high in the mineralocorticoid or aldosterone-like effect. It's a steroid that basically is like eating aldosterone. A person is brought to the emergency department after severe abdominal trauma and a motor vehicle accident. On the second hospital day, becomes markedly hypotensive without bleeding. And there's a fever and a high eosinophil count and hyperkalemia and low sodium and low glucose. What's the next step in the management of this patient? The answer is do a cortisol level and administer hydrocortisone, because norepinephrine is going to constrict blood vessels more effectively when there is steroids on board. So norepinephrine will constrict blood vessels better if you have those glucocorticoids. And treating severe hypotension is more important than finding the etiology. So CT scan of the adrenals is good, and cochentropin stimulation test is good, and even ACTH levels sometime. Dexamethasone suppression testing is the opposite. That's for hypercortisolism, not low. So choice C is important. It's not as important as preventing you from dying of hypotension today. Primary hyperaldosteronism, sometimes known as Conn syndrome, is actually much easier. It's basically an autonomous overproduction of aldosterone despite a high blood pressure. And it's an autonomous overproduction of aldosterone despite a high blood pressure and having a low renin. So that is from a solitary adenoma in 4 out of 5 patients. A smaller number have hyperplasia, and cancer, actual malignancy, is relatively uncommon. All forms of secondary hypertension are more likely than those who've had their onset of the hypertension too young, very young. You shouldn't be having high blood pressure when you're 20 and 25. And if you made it to 60 and 65, you shouldn't be starting. So if you're under 30 or over 60 or 65, or you're a person who can't get controlled by 2 meds, wow, you need a 3rd med and you're still not controlled? You need 3 meds? Wow, why? These are the people that we should be chasing secondary hypertension. Or if a person has something characteristic in the history and physical examination, such as primary hyperaldosteronism is characterized by high blood pressure and a low potassium. Those 2 facts alone are enough to tell you, hey, I think there's a primary hyperaldosteronism, high blood pressure and a low potassium. Aldosterone's raising your blood pressure, aldosterone's kicking out your potassium. For primary hyperaldosteronism, the best initial test is the plasma aldosterone to plasma renin ratio. In other words, a low plasma renin with a high aldosterone is primary hyperaldosteronism. It went up without renin. Now, the most accurate test is the adrenal venous sampling for high aldosterone. That's not necessary most of the time, but it is the most accurate test. And for the CT scan, well, like everything else in endocrine, only after the laboratory test reveals the diagnosis. A low potassium, low plasma renin, and high aldosterone despite a high salt diet. Remember, salt should shut off that aldosterone. If I give you a lot of salt, why is your aldosterone still up? Failure of feedback inhibition. Only scan after you already know it's there. A unilateral adenoma is easily removed with laparoscopy. That's why you're CT scanning them, to find out which side. Now, bilateral hyperplasia, you don't want to remove, so we use eplerenone or spironolactone to block it. Now, this question, spironolactone causes gynecomastia, decreased libido. It's anti-androgenic, very high yield because it's clear. It's a clear question. Pheochromocytoma is a non-malignant lesion of the adrenal medulla. It's the autonomous overproduction of catecholamines despite a high blood pressure. Like most of these tumors, it is the failure of feedback inhibition to shut it down. And pheochromocytoma is the answer if there is episodic hypertension. That's the number one thing. It's the only thing that's episodic. You don't have episodic renal artery stenosis. Oh, it came, it went, it came, it went. You don't have episodic Cushing's disease. Oh, I was humping and not humping. Oh, I had truncal obesity, no truncal obesity. It's the only one that's episodic. Headache and sweating and palpitations and tremor are certainly there. But it would be very hard to extrapolate and say, you have a headache, you must have pheochromocytoma. The answers for pheochromocytoma haven't changed in 30 years. We're going to get them right now. The best initial test, people sweat about this one a lot, so to speak, because people are torturing them with, well, what should it be? Plasma catecholamines, 24-hour metanephrines, catecholamines. Only thing we can say is that all of those are more accurate than VMA levels, vanilla mandelic acid, and you're not going to get asked to choose between them because it's just not too clear. Plasma catecholamines, 24-hour urine metanephrines, 24-hour catecholamines. Look, catecholamine levels go up, they go down, they go up, they go down. They last for a minute or two, and then they're gone. The urine tells you on average for 24 hours what's been going on. As in all of endocrinology, we only do scanning after we have confirmed it biochemically. You see symptoms, episodic hypertension, sweating, headache, palpitations, then the catecholamines and metanephrines. Then, after biochemical testing, then we scan the adrenals. Now, 10% are outside the adrenals. How would we find it? How do you find a pheochromocytoma that's not on that adrenal scan? Well, we have a specialized test that picks up occult pockets of enterochromaffin-like tissue. That's an MIBG scan, the abbreviation of which I don't want you to know. What does it stand for? It's a nuclear isotope scan, and it detects the location of pheochromocytoma that's outside the adrenal gland. Now, it's 10% are bilateral. 10% are outside the adrenal. 10% are malignant. We want to get rid of them. It's very important to determine the location so we can resect it. MIBG scan is a way of detecting occult pockets of pheochromocytoma. Now, this image is not because we expect you to be reading MIBG scans. We just want you to know, like, hey, isn't this cool? Look at this cool stuff we can do that can find occult pockets of these tissues. Wow. Mysterious. Wow, look at that, spooky. The best initial therapy is phenoxybenzamine, an IV alpha blocker that we give so that when we squeeze those adrenals, we don't cause your head to explode by a massive release of catecholamines. This is followed by beta blockers and rarely a calcium channel blocker, then remove it laparoscopically. These answers have not changed in 35 years. And you can occasionally be asked, episodic hypertension, catecholamines, metanephrines, scan, MIBG scan, phenoxybenzamine, beta blockers, and removal.